Now let's start with lower limb trauma. In this topic, we are going to discuss all the fractures and dislocations that occur in the lower limb. We'll be starting with pelvis and then moving down to femur, then tibia, and then the foot. Right? Now, this is interesting because this is something that you can actually feel and see. These are larger bones, so not a lot of imagination, and everything is visible clearly on radiology as well as clinically. Now, before we begin, I expect you to understand what the normal anatomy looks like, and then I'll show you that normal anatomy on X-ray, and only then you'll be able to appreciate what the pathology looks like, whether it's a fracture and dislocation. I'll be discussing the landmarks that you need to look for whenever you're trying to look for any normal or abnormal on X-ray. Okay? With that said, let's begin. Now, in front of you, this is an image of pelvis. Right? Pelvis. Now, what do you see here? These are the parts of the pelvis. What are the parts? This is one hemipelvis. This is the other hemipelvis. And what is this in the middle? This is your sacrum. Right? Now, can you tell me the name of this joint? This is the sacroiliac joint. Sacroiliac joint. You know this. Now, what is this opening here? This is obturator foramen, right? This is obturator foramen. Now, what are the parts of the pelvis? What are the parts of the pelvis? Let me show you this on the model that I have here. There are three parts to each pelvis, right? So one is the ilium, right? And then we have the ischium, and then you have the pubis. You have a superior and inferior pubic rami, and there is an opening known as the obturator foramen. Now, this is the acetabulum. This is the acetabulum, the cavity that accommodates the head of the femur to make the hip joint. Now, there is an anterior wall of the acetabulum, and then there is a posterior wall of the acetabulum. Okay. Now, let me show you how the head of the femur articulates with the head of the acetabulum. Head of the femur articulating with the acetabulum. So, the first thing you must have noticed by now is that the acetabulum is quite deep, unlike the glenoid in the scapula. So, acetabulum is quite deep, accommodating this large globular head of the femur. Right? So, this is the head of the femur. What else do we have here? You have the neck of the femur here. This is the neck of the femur. Right? And this part is the greater trochanter, and this part is the lesser trochanter. Okay? Now let me show this again on the image. This is the superior pubic ramus, the inferior pubic ramus, the ischium, right? The ilium, the obturator foramen, and what is this between two hemipelvis? This is the pubic symphysis. Now again, look at this now with the hip joint. You can see this is the head of the femur, the neck of the femur, the shaft of the femur, the greater trochanter and the lesser trochanter. Okay? This is the normal anatomy. This is how it looks like. Now let me show you an X-ray. Now look at the X-ray. Again, let's appreciate everything that we have just discussed. This is your sacroiliac joint. This is the ilium. This is the ischium. This is the pubic symphysis. This is the obturator foramen. This is the head of the femur, the neck of the femur, the shaft of the femur, the greater trochanter, the lesser trochanter. Right? Right. Are we missing anything? No. So these are the parts of the hemipelvis with the parts of the proximal femur. Now, before you understand anything, I want you to look for certain landmarks to appreciate what is normal from abnormal. Now, what are these landmarks that you should look for? Again, like I do with all my modules, everything is written in the PPT. I will show you the upcoming slide. Everything will be written. I just want you to pay attention. Listen to me, yaar. Listen to me. Appreciate what I'm trying to teach you. Connect with me, right? Only then you will be able to understand and grasp this thing. Writing you can do. PPT is there. You can copy. Okay. Now, the first landmark I wanted to look for is Shenton's line or Shenton's arch. Now, what is this Shenton's line or Shenton's arch? It is a continuous line which makes an arch, and it runs from one place to another, and it is continuous. The importance is that normally this line should be continuous, and if there is any pathology, this line shall be disturbed. Now, what is this line? This line starts from the inferior margin of the superior pubic ramus. This is superior pubic ramus, right? This is the inferior margin of the superior pubic ramus and runs laterally towards the medial part of the head of the femur, the neck of the femur, and then proceeds down. This arch is known as Shenton's arch or Shenton's line. It's a continuous line. Now, if there is any pathology, this line will be disturbed. What kind of pathologies? If there is a hip dislocation, if there is a neck femur fracture or proximal femur fractures, hip dislocations, osteoarthritis, avascular necrosis, any kind of pathology that affects the hip joint will affect this normal continuous line. Okay? Right, so this is the first thing you should appreciate. Second thing that you should appreciate, obviously, is that the head should be located inside the acetabulum. If it is not, then it is a dislocation. So it's a no-brainer. And obviously, there should not be any fracture line that is obvious to you. If there is an obvious fracture line, then it is a fracture. For example, if there is a fracture line running like this, what is it? It is a neck of the femur fracture. And if the fracture line is running like this, it is the intertrochanteric fracture. I will show you everything. I will show you again. I will show you again. Okay. So there should not be any obvious fracture. Now let me remove this. Now, what else should you notice? What else should you notice? You should notice that the tip of the greater trochanter usually coincides with the central of the acetabulum. Now, if this tip of the greater trochanter is proximally migrated, what does it suggest? If it's proximally migrated, what does it suggest? Limb lengthened or shortened? It is proximally migrated now, so it must be shortened. So limb is shortened. If it is distally migrated, if it is distal, what does it suggest? Limb is lengthened or shortened? The limb is lengthened, right? Just with X-ray, you know whether the limb is lengthened or shortened. So ye bhi nikal denge. We'll remove this. Now you've understood this. Now, the next thing I want to look at is the neck shaft angle. What is the neck shaft angle? Look at this. It is the angle between the neck of the femur and the shaft of the femur. This angle is known as the neck shaft angle. Now, what is the normal angle? Normally, it is somewhere between 125 to 130 degrees, and it is slightly more in children and reduces as the child grows. Okay, so this is the normal range. And if you recall this, the neck shaft angle increases. We call it coxa valga, and the neck shaft angle decreases, called coxa vara. I will show you. I will show you everything. Okay, so look at this. This is the head of the femur. This is the neck of the femur, right? So head, neck. This is the greater trochanter. This is the lesser trochanter. Now, normal angle is 125 to 130 degrees. If the angle is reduced, it's coxa vara. If the angle is increased, it's coxa valga. Now, my question to you is, if the angle is reduced, what does it imply? It implies that the GT has moved up. And if the angle is increased, what does it imply? It implies that GT has moved down. So, coxa vara mein length will be decreased. Coxa vara mein length will be decreased. It's obvious now. Neck shaft angle is reduced means GT will move to a higher level. So, length is reduced. So, I'll tell you the significance of this in a bit. Okay. So, that is the neck shaft angle. That is the thing that you should look for. So, if the GT is proximally migrated, or if the neck shaft angle is reduced, what does it imply? It implies that the limb is shortened. Right? Limb is shortened. So, coxa vara, if you recall, I've told you, and I've told you this in pediatric orthopedics, you can go and watch that video, is that whenever there is coxa vara, there will be three things that will happen. First of all, there will be shortening. Second of all, there will be Trendelenburg gait. Trendelenburg gait, which we'll discuss in this module. And the patient will have limitation of abduction and internal rotation movement at the hip. Just keep that in mind. You'll understand better later. Okay. So those are the things that you have understood. Anything left? Anything left? Yes. One last thing I want you to appreciate. This is a little extra. This is a little extra, little advanced point. But I'm sure you can understand this because it looks like all of you are very, very smart people. Now look at this. What is this small thing? What is this small thing over here that is visible? That is your lesser trochanter. Now, before you understand the X-ray, look at this. Now, this is an AP view, right? This is an anterior-posterior view. Normally, you're seeing the greater trochanter and you're just barely seeing the lesser trochanter, right? Lesser trochanter, you're just barely seeing. Now, if the limb is externally rotated, it becomes more obvious or more conspicuous in AP view. And if the limb is internally rotated, then it is disappeared. It is not visible in AP view. It is behind. So please keep this in mind, because when the limb is internally rotated, the lesser trochanter becomes invisible, and when the limb is externally rotated, it becomes more conspicuous or visible. So as promised, I'm showing you everything. We have discussed the parts of the hemipelvis. We have discussed the parts of the proximal femur. We have told you what lesser trochanter is and how it is visible on rotation, whether it's internal or external rotation. I've told you about Shenton's line. I've told you about the neck shaft angle and coxa vara. And the three things that happen with coxa vara is shortening, Trendelenburg gait, limitation of abduction and internal rotation with axis deviation, right? And I've told you if the GT is proximally migrated, there will be shortening. And if it is distally migrated, there will be lengthening. These are the things that I've told you. Now, once you've appreciated the normal, let's try to look at some abnormal images on X-ray to see what we can identify. Okay, not a lot of difficulty, not rocket science. Let's step by step approach it like how we have studied. So look at this. This is an X-ray of pelvis with both hip joints. Obviously, this side looks normal and this side looks abnormal. Okay, so first we'll do normal now, then only we'll be able to appreciate abnormal. So let's look at normal. Shenton's line, draw the Shenton's line running from the inferior margin of the superior pubic ramus with the medial part of the head and the neck. Continuous line, arch is maintained. This side is normal, no problem here. Head is inside the acetabulum, right? Neck shaft angle is approximately maintained and the tip of the greater trochanter coincides with the center of the acetabulum, means everything is normal on this side. Now look at this side. Start with the Shenton's line and the first thing you notice is the Shenton's line or Shenton's arch is broken. Right, so there is a pathology of the hip. What is the obvious pathology? The head of the femur doesn't look like it's inside the acetabulum, so must mean it's a dislocation. Is it a pure dislocation or is there an associated fracture? Looks like there is a pure dislocation because there is no other obvious fracture. Now, tip of the greater trochanter, obviously not coinciding with the center, slightly proximally migrated, means slightly shortening is there. Very good. And the thigh looks adducted, as in moving towards the midline, right? Neck shaft angle is maintained, because there is obviously no fracture. Neck shaft angle is maintained because even if there is a dislocation, even if the femur is freely moving, the neck shaft angle will maintain. Neck shaft angle will only be disturbed if there is a fracture here or if there is a congenital anomaly giving you coxa vara, right? And third, and the most subtle thing that you might miss if you're not looking for it, is the invisibility or lack of visibility of lesser trochanter, friends. See, lesser trochanter is not visible. And here the lesser trochanter is visible. Why is the lesser trochanter not visible? And what does it suggest to us if it is not visible? It suggests that the limb is in internal rotation or external rotation. Look at this. Limb is in internal rotation or external rotation? Internal rotation, right? So this is the acetabulum. The limb is in internal rotation. And if it's in internal rotation, the lesser trochanter disappears. Now look at the second exercise over here. Again, this is the Shenton's line and Shenton's arch maintained, normal side. Here's the Shenton's line. Disturbed, must be a pathology, and obviously head of the femur is not inside the acetabulum and tip of the greater trochanter is not coinciding with the center of the acetabulum, meaning it is at a lower level, meaning limb is lengthened and the thigh looks like it's abducted and the full visibility of the lesser trochanter suggests the limb is in external rotation. Okay, some idea you are getting, right? So these are the things that you will appreciate once you understand the normal. Now let's start with pelvis fractures. And the thing about pelvis fractures is they will ask you questions about how to manage an acute trauma with pelvis fractures rather than the management of pelvic fracture itself, which I'll show you in a bit. So before I say anything, let's quickly see what this pelvis fracture is all about. See, pelvis fractures are usually high velocity road traffic accidents or injuries that occur following a fall from height. Now, the moment I say fall from height, something comes to your mind. Jumper's fracture, right? Suicide jumper's fracture. Now, this fracture is a part of pelvis, but it occurs mostly in sacrum. So let me show you this. It is the U-shaped or H-shaped fracture of the sacrum. So jumper's fracture is an eponymous fracture, means it's a named fracture that you have to remember for your exam. So specifically remember jumper's fracture matlab sacrum fracture, U-shaped or H-shaped fracture seen in jumpers or suicide jumper's fracture. Keep that out of the equation. Now coming back to pelvis fractures, see, pelvis fractures have multiple classifications, but I just want you to know, for the sake of knowing the name, two: Tiles and Young and Bruges. In Tiles classification, pelvis fracture is basically divided into stable and unstable pelvic fractures. Now what are stable and unstable pelvic fractures? I'll tell you in a bit. Now unstable pelvic fractures are further classified based on the mechanism of injury. Whether the injury occurred from anterior or whether the injury occurred from the lateral or it was a complex mechanism of injury. You'll understand everything, trust me, and everything is written in the PPT. I want you to listen to me first, okay? Pura suno. Alright. So what is this stable and unstable pelvis fracture? Please understand, there is something known as the pelvic ring. So this is the pelvic ring. And the stability of this pelvic ring is essential for the stability of the pelvis. Now any fracture that disturbs this pelvic ring is considered as an unstable fracture. And any fracture that does not disturb the pelvic ring is considered a stable fracture. So what is this pelvic ring? It is part of this sacroiliac joint, sacrum, ilium, superior pubic ramus, pubic symphysis, superior pubic ramus, and the iliopectineal line. So this is the pelvic ring. For simplicity, this is the pelvic ring and pelvic ring. Now any fracture that affects anything other than that, it's considered stable. So this fracture, stable. 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 So any fracture that does not involve the pelvic ring is a stable fracture, and any fracture that involves the pelvic ring is unstable. Okay? I'll explain everything in detail later, but this is a general idea you should know. right? And now Young and Bruges classified the unstable pelvic fracture based on the mechanism of injury. Okay, clear hai? Let's proceed further and let's talk about what are stable fractures. Stable fractures, also known as type A fractures according to Tiles classification, are the fractures that do not injure the pelvic ring. These are the fractures of the ilium, the ischium, the anterior superior iliac spine, the anterior inferior iliac spine. Sorry, this is the superior, this is the inferior iliac spine. So any fracture that does not involve the pelvic ring is considered as a stable fracture. One important MCQ you need to remember is Duernes fracture. Duernes fracture is this fracture of the ilium. Okay, so this is your Duernes fracture. Try to remember it. They can show you it on X-ray, they can give you an image and put a label on it. This is known as Duernes fracture. Now, unstable fractures, type B fractures, they involve the pelvic ring and they are further classified based on Young and Bruges classification depending on the type of injury. Whether the force or the mechanism of injury was anterior-posterior compression, or whether it was a lateral compression, or whether it was a complex force. You will understand now? You will understand? Relax. Okay, now let's start with anterior-posterior compression force. What is this anterior-posterior compression force? Very interesting. Suppose you're standing against a wall, okay, with your back on the wall and you're looking in front of you. So this is the wall. And this gentleman has his back against the wall. Something comes and hits you from front. A car comes and hits you from front. So what will happen to your pelvis? It will be compressed antero-posteriorly. There will be an antero-posterior compression. That is the force. Antero-posterior compression force will give you open book fractures. What is this open book fracture? It's like your pelvis opens up. Your pelvis opens up. There is a pubic symphysis diastasis or pubic diastasis. This is known as open book fracture. Obviously, the ring is injured, so unstable fracture. So can you appreciate the fracture? This is known as open book fracture, also known as pubic diastasis. Which mechanism? Antero-posterior compression mechanism. Okay? Right. Moving on to the next mechanism, lateral compression force. Lateral compression force means you have the wall on the side. You have the wall on your side. Okay, and something comes and hits you from the other side. Suppose there is wall on your right side and somebody comes and hits you from the left side. So you're getting hit from the lateral force. So suppose this gentleman is standing against the wall, a car comes and hits him here. What will happen? There will be compression from the lateral side. So lateral compression force. You get two fractures here. One is Malgagne's fracture, other is bucket handle fracture. Malgagne's fracture and bucket handle fracture. So what is Malgagne's fracture? Malgagne's fracture is a fracture of the ipsilateral superior inferior pubic ramus with ipsilateral disruption of the sacroiliac joint. Look at this ipsilateral superior inferior pubic ramus fracture with ipsilateral sacroiliac joint disruption. Okay, right? Ipsilateral sacroiliac joint disruption, ipsilateral superior inferior pubic ramus fracture. Because of this, the pelvis will become unstable because the ring is disturbed. In APC, it was opening up like this. In this, it is going up and down like this. Now, what is bucket handle fracture? Bucket handle fracture is ipsilateral superior inferior pubic ramus and contralateral sacroiliac joint. Or you can say ipsilateral sacroiliac joint and contralateral superior inferior pubic ramus fracture. Doesn't matter. It just means that superior inferior ramus of one side and sacroiliac joint of the other side is affected. This is known as a bucket handle fracture. This is known as a bucket handle fracture. Okay? Okay, this is because of a lateral compression force. Both of them are unstable. Now, the third mechanism is the complex mechanism, the complex force. This will give you a straddle fracture. Here, there is a bilateral superior inferior pubic ramus. There are many more variations of this. This is one of the more common ones that you should know for your exam. So, superior inferior pubic ramus bilateral. This is known as a straddle fracture. Now let's talk about the management of pelvis fracture. But the interesting thing here is that nobody will ask you the specific treatment of the fracture in terms of how will you stabilize and fix the fracture, how do you plate it, how do you screw it. Nobody will ask you the management specific to the fracture. What they will ask you is the general management of pelvis fractures. Now, general management of pelvis fracture is very important because pelvis is mostly a cancellous bone. And since it's a cancellous bone, it bleeds profusely. And also, it has very important vessels around it. Okay, there are a lot of plexuses around it. So if there is a pelvis fracture, these bones can actually injure those vessels and cause bleeding. So what I'm trying to say is pelvis fracture is associated with lot of bleeding, which makes it a big problem. Which makes it a big problem. What is the problem here? Bleeding is the most dangerous complication. The patient will lose exsanguinating amount of blood. Exsanguinating amount of blood is lost. 1.5 to 2 liters of blood is lost. The average human being has 5 liters of blood. An average, healthy. Imagine an Indian. A malnourished Indian will have less than that. Right? And we lose 2 liters. That's 40 to 50% of your volume. That's around 4 to 8 of units of blood. The patient will be in hemorrhagic shock. Most of the patients with pelvis fracture usually die because of hemorrhage itself. Right? So that's a big problem, and that's what we need to address. The second thing is, because the pelvis is protecting important soft tissue viscera inside, they can also get injured. And once they get injured, they can cause their problems. There is an MCQ that is asked usually. What is the most common soft tissue injury associated with pelvis fracture? The most common soft tissue injury associated with a pelvis fracture is urethral injury. You will read this more in urology, and they will tell you what about it, right? Everything about it, right? So pelvis fracture, massive amounts of blood loss because cancellous bone and lots of venous plexus around it. So focus on management of blood loss. So whenever there is a lot of blood loss, we will talk about ATLS. Basically, pelvis fracture management is a part of ATLS because pelvis fractures usually occur because of high velocity forces, high velocity traumas. High velocity trauma patients are managed by ATLS. And if you recall, what is ATLS? Advanced Trauma Life Support, right? In the beginning of our orthopedic modules, we have discussed this. What is ATLS? It is a simultaneous diagnostic and therapeutic activities. They are therapeutic and diagnostic activities whose aim is to basically identify and treat life and limb threatening injuries. That is, it's a therapeutic and diagnostic activity aimed at identifying and treating life and limb threatening injuries. Starting from the most immediate problem. So we have stages of management. If the patient is not in cardiac arrest, in order to prevent the patient from deteriorating because of injuries. What do you mean? You see, I've told you about this in the basics also. There is BLS, there is ACLS, there is ATLS. See, BLS and ACLS is for patients who are in cardiac arrest. ATLS is not for cardiac arrest, it's for polytrauma patients. So if a patient is in cardiac arrest, a sick patient is in cardiac arrest, then you are going to do your BLS and ACLS. We're talking about polytrauma patient here. So polytrauma patients, you are going to do ATLS, right? So ATLS mein kya hai? You have your A, B, C, D, E. A is airway with cervical spine stabilization. B is breathing. C is circulation. D is disability evaluation with the help of Glasgow Coma Scale. E is exposure management or controlling of hypothermia. So remember, A is for airway with cervical spine stabilization, B is for breathing, allowing for the chest to expand, C is for circulation, mitigating or controlling the blood loss. This is where the pelvis fracture problem comes in. You have to control the blood loss. D is for disability evaluation, Glasgow Coma Scale, everything you will read in general surgery. E is for exposure or environment control, preventing hypothermia. Now they are arranged so that from A to E, patient usually die very rapidly if A is not addressed, within a few days if E is not addressed, right? So A is the most important, B, C, D and E. So from the most important to least important, but all of them are generally important. But in pelvis fracture, I've told you, we are going to focus more on the C, the circulation, the blood loss. So aim is to stop the bleeding. And how will you stop the bleeding in pelvis fracture? In pelvis fracture, see, whenever there is bleeding, your aim is to basically tamponade, compress it to decrease the blood loss. Now, how will you compress the bone? You do pelvic tamponade. How will you do pelvic tamponade? You bind the pelvis, and that is how you compress the pelvis. So what are the 3 most important things you need to do in order to control or manage bleeding in a patient with pelvis fracture? The first thing you do is you apply a pelvic binder, and I will show you everything. I have all the images for you. Pelvic binder basically is wrapped around the pelvis to compress it. And when you compress it, you are providing tamponade. You are providing tamponade to control the bleeding, right? So pelvic binder is the first thing you should do. Once you have applied the pelvic binder, immediately start resuscitation. Give the patient fluid that he has lost. Ideally give blood. If blood is not available, then you can give Ringer lactate more than normal saline to restore the volume. Ringer lactate more than normal saline. Ringer lactate is preferred more than normal saline because theoretically it gives some advantage. In patients in acidosis. Theoretically, so let's stick to it. Ringer lactate more than normal saline. Now, after you started the resuscitation, the next step is to basically apply the external fixator to the pelvis in compression mode. I'll show you. So basically, pelvic binder is something that is temporary. Start the resuscitation, and something more substantial and robust is an external fixator in compression mode. So these are the 3 things you will do whenever there is a patient with pelvis fracture who is unstable. So this is a patient lying in front of you, and we are applying a pelvic binder. Since we do not have anything that is a proper pelvic binder like thing, we are taking a bed sheet and we are wrapping it around the pelvis. We take a bed sheet and wrap it around the pelvis. The whole aim is to basically compress the pelvis. That's it. That's it. If you can't find a bed sheet, use a dupatta or an orni or anything. Any sheet will do. A towel, anything will do. Okay. So look at this. This is what they have done. They have wrapped a sheet and they have tightly, snugly applied it. And this is a proper pelvic binder with the straps and Velcro. After you have applied this, start the patient of IV fluids to replace the blood loss, and then find time to take the patient to the emergency theater and apply the external fixator in compression mode. This is what we are doing. We are applying the external fixator in compression mode here. It's the same external fixator which we use for open fractures, but here we are using it in compression mode to provide tamponade. Now let's quickly talk about acetabulum fractures and then move on to the further topics. Now this is the acetabulum, right? This is the acetabulum. Nice cavity to accommodate the head of the femur. Sorry, it makes an honest mistake. It happens. Femur and humerus, I get confused, but we are talking about femur now, not humerus. It's a femur, right? Now, so this is the anterior wall of the acetabulum. This is the posterior wall of the acetabulum. Now there is an anterior and posterior column as well. So it is supposed to be this iliopectineal part. Also, it starts with the ilium and then goes to the superior pubic ramus. And the ilioischial part, this is supposed to be the posterior column. Even if you don't understand it, it's okay. So there are two walls and two columns basically supporting the acetabulum. So the fractures of acetabulum are basically classified by Judet classification, and this was asked once, and it has two columns and two walls. So the fractures of acetabulum are classified by Judet classification into anterior wall fracture, a posterior wall fracture, an anterior column fracture, a posterior column fracture, and a bicolumnar fracture, and various other combinations of anterior column and wall with posterior column and wall, those kind of combinations. But nevertheless, nobody will ask you that. What they want you to know is the name of the classification, Judet classification. And the second thing is, in bicolumnar fracture, you get a typical radiological finding. You should know the name for your exam. It's called as the spur sign. Asked once, long time ago. Now, there is one X-ray view you should know for acetabulum fractures, and this has been asked multiple times. It's Judet view. So what are the views you use for acetabular fractures? You use Judet views. And you see two things in Judet views. Apart from the anterior wall and the posterior wall, you look for the columns also. And there are two lines that you can draw. Just know the names of the line for the sake of your exam. One is the iliopectineal line, runs like this. And the other is the ilioischial line that runs like this. Okay, so iliopectineal line gives a radiographic landmark of the anterior column. So if it is disturbed or disrupted, means anterior column is fractured. Ilioischial line gives a radiographic landmark of posterior column, and if it is disturbed, what does it imply? It implies that the posterior column is disturbed or fractured. Now moving on to three important tests that we need to remember for our exam. Although not all of them are for the hip, but they are in lower limb nevertheless, so let's discuss them. The first most important test, probably very, very important for your exam, is Trendelenburg test. And a lot of students find this confusing. Now, what is the aim of this test? Basically, the aim of this test, again, everything is written in the PPT. Please listen to me. Please understand. Please grasp the concept. And then you can write down everything. Like I said, everything is there in the PPT. Now, the aim of this test is to basically assess the abductor mechanism of the hip. Now, what is abduction of the hip, friends? Abduction of the hip is this maneuver, this mechanism. This is abduction of the hip. Now, what are the principal abductors of the hip? What are the principal abductors of the hip? Gluteus medius and minimus are the principal abductors of the hip, not maximus. Medius and minimus. Recall what is the nerve supply of medius and minimus? It is superior gluteal nerve. Important muscles supplied by superior gluteal nerve. Who is supplied by inferior gluteal nerve? Gluteus maximus. So not so important. Just remember that. So superior gluteal nerve supplies gluteus medius and minimus. Important for abduction of the hip. Now, this is the abduction of the hip. Now, if you're standing on one limb, if you're standing on this limb and contract your abductors, can you imagine what will happen? These abductors will contract, and instead of the thigh or the lower limb going into abduction, what will happen? The pelvis will start to tilt. The pelvis will start to tilt. This is what happens. This is what happens when we walk or gait. Now, you see, when we are walking, one of our limbs will be in the stance phase and the other limb will be in the swing phase. Now, for the limb to swing, the pelvis has to be tilted or has to come up so that the swinging limb can swing easily without touching the ground. So look at this image over here. Here, the patient, this limb is in the stance phase. It's standing on the ground. And so this limb is moving up to swing easily. Now, who is bringing this pelvis up? This abductor. This abductor is basically tilting the opposite pelvis up, right? So my right abductors will tilt the pelvis so that my left hip goes up. And when I'm standing on the left side, my left abductors will contract so that my right hip will go up so that I can swing from my right. Are you able to appreciate this? Are you able to appreciate this? Let me show you again. So if this is the right side of the person and he's standing on the right side and the right side is in the stance phase, what will happen? If the left limb starts to swing, immediately these abductors will activate and tilt the pelvis so that the left side can swing easily. So what do you need? You need proper abduction. And who brings the abduction? Gluteus medius and minimus with its superior gluteal nerve. Also remember, I told you coxa vara. What happens in coxa vara? The neck shaft angle decreases. And when the neck shaft angle decreases, the tip of the greater trochanter migrates a little proximally. Right? Because neck shaft angle decreases, this comes a little proximally. And when GT comes a little proximally, what happens to the length of the gluteus medius and minimus? The length decreases. So when the muscle length is decreased or the muscle becomes lax, its strength decreases. Remember Frank Starling law? A stretched myocyte is a strong myocyte. And here in coxa vara, because the GT is migrated proximally, the abductor becomes relaxed. Let me show you. Suppose the attachment of the abductor starts, say, 2 inches from the center of the head of the femur. 2 inches from the center of the head of the femur. Okay. Now look at this length versus look at this length. This is the length of your abductors. It is definitely shortened or decreased in coxa vara. It is reduced in coxa vara because in coxa vara the neck shaft angle is reduced and the GT goes proximally. So at the end of the day, what happens when there is an abductor failure? Now look at this image. In this image, this abductor is fine. So when the patient is standing on this limb, this abductor contracts and brings this pelvis up or the contralateral side up. Now, when the patient stands on the pathological side, this right side, when the patient stands on the pathological side, there is failure in abduction. It can be because of coxa vara, it can be because of superior gluteal nerve palsy, it can be because of gluteus medius and minimus palsy. Whatever it is, abduction fail. Okay? Abduction is failed. When the abductor is failed, the opposite healthy side will start to sink down because there is nothing below it to hold. It will sink down. So in other words, what is the point here that I'm trying to make? In abduction failure, there will be Trendelenburg positivity and the sound side or the healthy side will sink. Now when the healthy side will sink, the patient would want to bring it up. And how will he bring it up? By turning or lurching towards the pathological side. So look at this gentleman here. His abductor is failed. So the healthy side is sinking. And in order to bring it up, he is lurching towards the pathological side. Are you able to appreciate it? Are you able to understand this? A little bit is enough. You understand a little bit because everything is written and once you read it once or twice, you'll understand it better. Are you able to appreciate what I'm trying to tell you? If he's standing on the pathological side, the abductor of the pathological side is failed. So the healthy side will sink and he will lurch towards the pathological side to bring the healthy side up. When he stands on the healthy side, everything shall be fine. The pathological side will not sink down because the healthy side's abductor is bringing the pathological pelvis up and normal. Right? Appreciate that. Now, how do you perform the test to make a diagnosis of abductor mechanism failure? We perform the Trendelenburg test. What do you do in this test? You basically ask the patient to stand on each side for 30 seconds to assess the integrity of the abductor mechanism. Now let me show it to you. What I'll do is ask this gentleman to stand on each limb for 30 seconds and I will notice what happens to the other side. Now what is the landmark that you're looking for? You're looking for anterior superior iliac spine. Instead of looking at the anterior superior iliac spine, I know that the belt of this pant is making a line on the anterior superior iliac spine. For simplicity of understanding, I will look at the belt of his trouser. So if I ask him to stand on his good side, please stand on your good side. What do you notice? You notice that the pelvis remains straight because it is not sinking down. These abductors are working very nicely to bring this side up. His shoulders are at the same level, his spine is straight. Now what if this side is pathological or damaged or diseased? What will happen? There will be a failure in the abductor mechanism and this side will sink down and he will be lurching towards the pathological side, and he will be unable to stand on this limb for 30 seconds. So this limb is the bad limb or has the pathology, or this is the limb which has Trendelenburg test positive. Now sometimes the patients are unable to stand on one limb, so you will need to support them with your hands and ask them to do the test same. This is known as assisted Trendelenburg test. Please stand, sir. You will notice that the pathological side is falling down and he's taking support with his hands to stand. This is known as assisted Trendelenburg test. Now, a simple way to remember all of this is when a patient stands on the pathological side, the sound side or the healthy side will sink down. So the sound side sinks when the patient stands on the pathological side. So Trendelenburg positive and the healthy side will sink down. So what are the requirements of a normal gait or a normal person? Normal abductors of the hip, both muscle and the nerve, and normal level of the trochanter, means no coxa because coxa reduces the length of the muscle, hence there is weakness. Frank Starling. Now, what are the pathologies that cause a positive Trendelenburg test? Anything that can disrupt the superior gluteal nerve, gluteus medius, minimus, and cause coxa. All of this is written here. So as promised, what is written here? Gluteus medius and minimus are primary abductors of the hip. They are both supplied by superior gluteal nerve, and when the leg supports the weight of the body on the lesion side, or when you stand on the pathological side, there is dipping or sinking of the pelvis towards the healthy or the contralateral side. And why does this happen? Because the pelvis cannot be maintained in level plane by the lesioned abductors or pathological abductors. The patient falls towards the healthy side. And when the patient falls towards the healthy side, he wants to lurch towards the pathological side to bring the healthy side up and leans to the torso towards the lesion side to maintain the balance. This type of gait is known as a Trendelenburg gait, right? Are you able to understand? So if I'm standing on the pathological side, the healthy side will sink down and I will lurch towards the pathological side to bring the healthy side back up. This kind of gait, every time you put weight on the pathological side, you lurch towards it to bring the healthy side up, is known as a Trendelenburg gait. So what are the steps to perform the Trendelenburg test? Look at this. Patient should be standing. Patient should be standing. And you can stand either in front or behind the patient, and you have to expose either both the anterior superior iliac spines or both the posterior superior iliac spines. Why? Because they are the landmarks to look for whether the pelvis is dipping or not. They are the landmarks to look for whether the pelvis is dipping or not. Patient is asked to stand on the normal side first. When the patient stands on the normal side, friends, what will happen? The normal abductors will contract and the other side will be brought up. There will be no abnormality. Everything should be fine. Stand on the normal side with the affected side foot off the ground. The affected hip is kept in extended or flex, doesn't matter. Nothing will happen. The ASIS or the PSIS on the affected side should move upwards or at least stay at the same level. So when he's standing on the normal side, the pathological side either comes up or at least stays at the same level. But when he stands on the pathological side, the healthy side will go down because the abductor is failed. When the patient is asked to stand on the affected side, keeping the normal side foot off the ground, what will happen? What will happen? The healthy side will sink down. So what is the inference? The test is positive if ASIS or PSIS, depending on whether you're standing in front or back, of the normal side goes down while weight bearing for 30 seconds. So you ask the patient to stand on the pathological side for 30 seconds and then you will notice the healthy side will start to sink. Okay? If still did not make sense to you, again I'll give you a simpler version of this. Look at this. What is Trendelenburg test for? It is used to assess the abduction of the hip. Okay. What are the abductors of the hip? Gluteus, medius and minimus. Alright. What are they supplied by? They are supplied by superior gluteal nerve. Very good. Now on nerve damage or muscle damage. So one of these three things, if damaged, what will happen? Patient will be unable to abduct. Very good. So when he is unable to abduct, what will happen? He will be unable to tilt the pelvis back to neutral. So here there is abduction failure. So he is unable to tilt the pelvis back to neutral because these abductors are not able to contract. So what will happen? They will be sinking of the healthy side. They will be sinking of the healthy side. So what is the terminology we use? We use positive Trendelenburg for this side. So this is a positive pathological side. So healthy side or the sound side will sink. So positive is the pathological side and the sound side will sink. So this is known as positive Trendelenburg test. So here in this image, the right side of the individual is affected. So right side is positive Trendelenburg side. Left side is the normal or the healthy side. So left side hip tilts down. So the sound side sinks. So remember, positive Trendelenburg is the pathological side and the sound side sinks. Right? And if you have a unilateral Trendelenburg gait, that's called a Trendelenburg gait. And if you have a bilateral Trendelenburg gait, imagine what will happen. Every stance phase, you will be lurching towards the pathological side. So on one step, you'll be going here. On the other step, you'll be going there. That is known as waddling gait due to bilateral failure of abductors. I am sure it is clear now. If not, pause, go back, read and watch the video again. Trust me, you'll be able to understand. The key words to remember is positive side is the pathological side, sound side sinks, and we are testing the abductors of the hip, which are gluteus medius and minimus, supplied by superior gluteal nerve. So any pathology of superior gluteal nerve, gluteus medius or minimus or coxa vara will cause Trendelenburg gait or Trendelenburg limp or Trendelenburg test positive. Now let me explain and demonstrate the Trendelenburg test to you. The simple terms I will use to explain is the good side and the bad side, instead of using the typical healthy side and the pathological side or the lesion side, where there's a lot of confusion. Just remember the good side and the bad side. Now, what is the Trendelenburg test for? It is basically to assess the integrity of the abductor mechanism of the hip. What is the abductor mechanism of the hip? The abductor mechanism of the hip comprises of the gluteus medius and minimus, which is supplied by the superior gluteal nerve. Now, what is the action of the gluteus medius and minimus? They are the principal abductors of the hip. Their action is to basically abduct the pelvis or abduct the hip. So this is what happens when they contract. They abduct. When they abduct, they are essentially bringing the other side of the pelvis up. Can you notice this? Can you observe? On abduction of my left hip, what happens? My right hip comes up. This is their action. Now, you may ask me, why is it performed? It is performed because when we walk, there is something called as a gait. Gait is when we are walking. Now, while we are gaiting or while we are walking, one limb will assume a stance phase while the other limb is in the swing phase, and only then we can propel ourselves forward. For example, when I'm walking, you will notice, so one limb will be in the stance phase, the other limb will be in the swing phase, and only then our body will be propelled forward. Now, please pay attention. While one limb is in the stance phase, the other limb needs to be swinging. So this pelvis needs to go a little bit above the ground for us to swing forward. So who brings it up? This side brings it up. This side brings it up. Now, if there is any pathology over here, do you think this side will come up? No, this side won't come up. Instead, this side will fall down. So if I have a bad left hip, my good right side will sink down or fall down. So I will be unable to swing my good side because my bad side isn't able to bring the good side up. Are you following? Again, let me repeat this. So if this side, gluteus medius or minimus are affected, or if the superior gluteal nerve is paralyzed, what will happen? I will not be able to abduct. So if I am unable to abduct, I will not be able to bring the good side up. So whenever I am walking, my good side will sink down and I will be unable to move forward. So what will I do? I will compensate by lurching towards the bad side to bring the good side up. I will be lurching towards the bad side to bring the good side up. So let me show you how I will walk. Every time I put my weight on the bad side, my good side will sink, and when it sinks, I will be unable to proceed forward. So I will lurch towards the bad side to move forward. Look at this. This is my Trendelenburg gait. Now what if both the sides are failed? Now if both the sides are failed, I will have a bilateral Trendelenburg gait known as the waddling gait. This is how it looks like. Now in patients with polio, we understand that they have quadriceps palsy. And because of quadriceps palsy, they will be unable to extend their knee. Keeping the knee in extension is an essentially important requirement for walking, because in the stance phase, if you recall, your knee should remain in extension for the body to propel its weight forward. The knee should remain in extension for the body to propel itself forward. Now in patients with polio who have quadriceps palsy, the knee will not remain in extension because there is weakness in the quadriceps. So every time the patient is in stance phase trying to propel his body forward, you will notice that the knee will buckle and go into flexion. So this is what will happen. Every time he tries to move forward, the knee will flex, unable to go forward. So this individual, in order to proceed forward, will try to keep the knee in extension with the help of his hand. He will place his hand on the knee as he walks to keep it in extension, and when the knee remains in extension as he walks, he will be able to proceed further. So this is the kind of gait this individual will have. He will put the leg out, put the hand on the knee to prevent its flexion, and then he will move his body forward. This is your hand to knee gait seen in patients with quadriceps weakness or palsy in poliomyelitis. Now the next test we are going to talk about is also a very important test asked in recently Central Institute exam, right? So this is Thomas test, obviously described by H.O. Thomas, father of British orthopedics. Now it's in the name. It is a Thomas well leg raising test. So keep that in mind. It means that we are moving the well leg to identify the pathological site. So look at this. Basically, Thomas test is a test to reveal the concealed flexion deformity or flexion contracture of hip. So what is the problem here? The problem is in the hip, but there is a flexion problem. So flexion problem is this plane, sagittal plane. Trendelenburg test was for abduction, right? So that was coronal plane test. This is a sagittal plane test. Anyways, so the problem here is there is some deformity at the hip. And what is the deformity? Flexion deformity or flexion contracture. Now, again, everything is written. Just listen. Now, whenever there is a pelvic contracture or hip contracture, please understand that the lumbosacral spine compensates for this contracture by going into lordosis. Because at the end of the day, lumbosacral spine and pelvis together basically balance each other out to maintain your posture. There is a balance between them. They move in harmony. If pelvis tilts more, lumbosacral compensates. If there is lumbosacral tilt, pelvis will compensate. They balance each other out. So in flexion contracture of hip, there is a contracture deformity of the hip, flexion deformity. So pelvis is tilted. Pelvis is tilted because the patient wants to walk. If the patient is tilted, what happens? The lumbar spine compensates and exaggerates the lordosis. So let me simplify it for you in terms of a diagram. I know it's a little confusing, but I'll simplify it for you. Look at this. Suppose this is your back and this dot is your hip joint. This dot is your knee joint and this dot is your ankle joint. And imagine you're lying down. This is from a lateral view, you're lying down. Now, if there is a problem here at the hip joint, what problem did I say? There was a flexion contracture of the hip. Means there will be hip flexion like this, right? Okay, so this is a flexion contracture. That is a flexion contracture of the hip. Now, in order to compensate for flexion contracture, pelvis will tilt to keep it straight, to keep the limb straight. So what will happen? It will become like this. But who will compensate for this pelvic tilt? Your lumbar spine. Are you appreciating now? Are you appreciating? Your lumbar spine. Your lumbar spine will go into exaggerated lumbar lordosis. Exaggerated lumbar lordosis. So are you able to appreciate what is happening here? So the hip contracture is being compensated by the lumbar spine by lordosis. Now the aim of the test is to disturb this compensation, right? To remove this compensation. To reveal what? To reveal the flexion contracture of the hip. So what we are trying to do here is we are trying to remove the lumbar lordosis to reveal the flexion contracture. So what the examiner will ask the patient to do is flex the normal hip side. Flex the normal hip side. So when you flex the normal hip side, the pelvis will tilt back. The pelvis will tilt back. And once the pelvis tilts back, the lumbar lordosis is lost. Lumbar lordosis is lost. Once the lumbar lordosis is lost, can you imagine what will happen? Lumbar lordosis is lost. Immediately, the hip flexion will reveal itself. So look at this. This is what is happening. The patient has an extended hip and an extended knee, and this extended hip is brought about by exaggerated lumbar lordosis because it's compensating for the pelvic tilt. Now, once you start flexing the normal side, the pelvis goes back to neutral lumbar lordosis disappeared. And once the pelvis goes back to normal, the flexion contracture will reveal itself because it was being concealed by the compensatory lumbar lordosis. Okay? So look at this. You make the patient lie down supine over a hard couch and both the limbs are parallel to each other. Right? Then what do you do? If there is an exaggerated lumbar lordosis, normally there should not be. If there is, it means that the lumbar lordosis is compensating for some pelvic tilt. Then what should you do? You should immediately put your hand. The examiner can insinuate his hand between the spine and the couch. So this is where the examiner will put his hand. Normally it should not go. But if there is a lumbar lordosis, then it will go. Now keeping the hand under the exaggerated lordotic spine, the normal side, the normal hip is gradually flexed. The normal hip is gradually flexed, keeping the knee in flexion till when? Till the lumbar lordosis disappears. So normal side is flexed. Normal side is flexed till the lumbar lordosis disappears. Now how do you know lumbar lordosis disappeared? You cannot pull the hand out, and if you pull, you cannot put it back inside. Okay. Once they're taken out, the hand cannot be insinuated again. It means the lumbar lordosis is obliterated. Means the compensation is gone. Now whatever deformity is there is the deformity that is there in the pelvis. At the same time, the affected hip will immediately go into flexion because the lumbar lordosis is lost. The compensation is gone. The deformity starts to reveal itself. Now ask the patient to hold the unaffected knee or the healthy knee in flexed position like this in hand while you measure the deformity. While you measure the flexion of the affected hip. Are you following me? This is your Thomas test. This is your Thomas test. So simplification, Thomas test is for flexion contracture of hip. This is a direct MCQ. Flexing the normal hip causes the disappearance of lumbar lordosis, and once the lumbar lordosis is gone, the flexion contracture or the pelvic tilt will reveal itself. This reveals the flexion contracture of the pathological hip. Is this clear? Are you able to appreciate this? Let me show you an image here. We have asked the patient to flex the normal hip, and once he does that, the deformity will reveal itself on the other side. So this is Thomas well leg raising test. So we are raising the well leg or the healthy leg. Now let me demonstrate a Thomas test to you. But before I do, let me ask you a simple question. What is Thomas test used for? Thomas test was described by H.O. Thomas, Hugh Owen Thomas, and it is also known as Thomas well leg test. Now can you tell me what it is used for? It is used to assess the flexion contracture or the flexion deformity of the hip. Now how do you begin this test? The first thing the examiner should do is assess for a lumbar lordosis. Now how do you go about doing that? There are two ways of doing it. First, you can directly visualize the lumbar lordosis that is exaggerated, or you can insinuate your hand under the lower back. Normally, you are not supposed to be able to pass your hand or insinuate here because this patient has an exaggerated lumbar lordosis. You are able to insinuate or pass your hand under the lower back. Now, if this is there, if the lumbar lordosis is exaggerated, it obviously means that there is a pathology. Now, the pathology in question here is at the hip. The problem is there is a flexion contracture of the hip, but it is not visible right now. Right now, it looks like everything is normal. The test basically helps us reveal this concealed deformity of the hip. Now, how do we go about doing it? We basically flex the normal hip. This is the normal hip. This is the pathological hip. We flex the normal hip passively, so much so that this lumbar lordosis that is exaggerated is obliterated. Now, as it is obliterated, I will ask the patient to hold this flexed knee with his own hands, and you will realize that as I pull my hand out, I will be unable to pass it inside again because this lumbar lordosis is now obliterated. Now, while this lumbar lordosis was obliterated, we did not realize that this other side suddenly revealed its concealed flexion deformity. This is the actual flexion deformity of this pathological side that was being concealed by exaggerating the lumbar lordosis. Now, how do you measure this flexion contracture of the hip? You use a device known as the goniometer that helps measure the angle, and you measure the angle of the flexion deformity with the horizontal of the table and the shaft of the femur. As of right now, it looks like it is somewhere around 30 degrees of flexion deformity of the hip. So if you want me to simplify it for you, let's quickly review it in 3 steps. The first step is to look at the lumbar lordosis. It is exaggerated, right? And then flex the normal hip so much so that the lumbar lordosis is obliterated. Ask the patient to hold the flexed hip and observe the flexion deformity of the pathological side. This is your Thomas test. Now, if you need to understand the biomechanics of it, let me explain how. Now, this part is a little extra for you. If you do not understand it, it's okay, but try to listen what I'm trying to tell you. See, this is the normal movement at the hip. If the patient has a pathology in which his hip is in flexion deformity, if his hip is in flexion deformity, he will be unable to walk properly. So in order to walk properly, what he will do is he'll try to keep his limb straight. Now, in order to keep a limb straight with a flexion deformity, what happens is as you try to tilt the hip, the pelvis tilts with it because it's in flexion contracture or flexion deformity. So if you want to keep the legs straight, you need to tilt the pelvis. Now, whenever the pelvis is tilted, the lumbar spine lordosis is exaggerated. And that is what is happening here. Now, this is a patient who is lying like this, exactly like this. His lumbar spine has an exaggerated lumbar lordosis, and you can actually insinuate your hand underneath it. The moment I ask the patient to flex the normal side, what is happening is the pelvis tilts back to normal. Hold it. The pelvis tilts back to normal. The lumbar lordosis is lost, and the flexion deformity of the hip is suddenly revealed right in front of your eyes. This is Thomas test. Simple steps. Lumbar lordosis exaggerated. Obliterate it by flexing the normal hip. The pathological side will reveal itself. Finally, the last t-test that I want you to know is not for the hip, is Thompson test or Simmons-Thompson test. It is basically to assess the integrity or the continuity of the Achilles tendon or the tendoachilles, whatever you like to call it. Now, what do? You squeeze or you compress the gastrosoleus complex. When you squeeze or compress the gastrosoleus complex, what will happen? As it is compressed, there will be contracture. So the foot will go into plantar flexion. The foot will go into plantar flexion because on squeezing, it will pull the muscle and the tendon. This will give you plantar flexion. Now, if there is any injury of tendoachilles where it is disrupted or cut, on squeezing the gastrosoleus, the tendon will contract, but it will not pull the foot into plantar flexion. Are you following? Are you appreciating? So these are my flexors, right? If I compress my flexor, squeeze my flexors, my wrist will go into flexion. If there is any disruption here on squeezing this, nothing will happen. That is what it is. On squeezing the gastrosoleus complex, there is plantar flexion normally. But if there is a disruption of the tendoachilles, this does not happen. This is known as Thompson test, not to be confused with Thomas test. Now, this is Simmons-Thompson test or Thompson test. The purpose of this test is to assess the integrity of tendoachilles. Now, tendoachilles is basically the tendon that is the tendon of gastrosoleus complex. So, gastrocnemius and soleus muscle complex ends as a tendon that is tendoachilles and inserts at the calcaneum. Now, what is the function of gastrosoleus or gastrocnemius and soleus? Their function is to basically pull the calcaneum up, that is to cause plantar flexion of the foot. That is their function. So if a person has a normal gastrosoleus complex inserting on the calcaneum through the tendoachilles, what will happen if the gastrosoleus complex contracts? There will be plantar flexion. Now, the aim of this test is to assess the integrity of this tendoachilles, because in certain injuries, the tendoachilles will be ruptured. So this is a test to assess the integrity of tendoachilles or a test for tendoachilles rupture. Now, how do you perform this test? You make the patient lie down prone here and you squeeze the gastrosoleus complex with your hand. Now, the moment you squeeze the gastrosoleus complex, what will happen? The muscle will contract because you are squeezing it. The tendoachilles will be pulled and the foot will go into plantar flexion. Let me demonstrate it for you. pay close attention to the foot as it is getting plantar flexed while I squeeze the calf muscles. Are you able to appreciate it? The moment I squeeze the calf muscles, there is plantar flexion. This is your normal individual. This will be better exaggerated also if we flex the knee to 90 degrees and squeeze it like this. Are you able to appreciate it? Are you able to appreciate the plantar flexion as I squeeze the gastrosoleus complex? This is in a normal individual. Now, if a patient has a tendo-Achilles rupture over here, however much you squeeze, there will be no plantar flexion because the continuity is disturbed. Even in 90 degrees of flexion, as well as hanging it down, there will be no movement on squeezing of the gastrosoleus complex. This is your Thompson test, not to be confused with Thomas test that is used for flexion contracture of the hip. Now let's start with a very, very important topic for your exam. I think every alternate exam will have a question from this topic. This is dislocations of hip. And posterior dislocation is a standard question. You should know everything about it. So essentially, what is dislocation of hip? Dislocation of hip means the head of the femur escapes the acetabulum. The head of the femur coming out of the acetabulum. Now the dislocations of the hip can be anterior, can be posterior. Now these are called pure dislocations. There can also be fracture dislocations where with the dislocation there can be an associated fracture, as in posterior wall of the acetabulum can get fractured, anterior wall can get fractured, or the head of the femur can get fractured. Those are complex dislocations, but we'll be talking about all of them. But please understand that if you recall from shoulder dislocations that we read in upper limb, the most common complication of shoulder dislocation was recurrent shoulder dislocation because it was a very unstable joint. Whereas hip is actually very, very stable joint because it is surrounded by very, very strong ligaments all around. The strongest ligament of your body, the iliofemoral ligament, actually supports the hip joint. That is why the complication of hip dislocation is not recurrent dislocation. In fact, once it gets dislocated, it actually becomes difficult to reduce it even, right? So please understand that hip is a very stable joint and recurrent dislocation is not its common complication. Now, what are the types of dislocations of the hip? Like I said, there can be pure dislocations. These are pure dislocations where the head comes out of the acetabulum, and there can be fracture dislocations. Okay. Now pure dislocations can be posterior, can be anterior, and the most common is posterior. Now fracture dislocations can be posterior, can be anterior, as well as central fracture dislocation. Please understand, people get confused. Sometimes they say central dislocation. Central dislocation is not the proper term. It's a central fracture dislocation because for the head of the femur to dislocate centrally, it has to fracture the acetabular floor, and only once it has fractured the acetabular floor, it will come inside the pelvis, right? So normally a pure dislocation can be an anterior pure dislocation. It can be a pure posterior dislocation. It can be an anterior fracture dislocation. It can be a posterior fracture dislocation, and it can be a central fracture dislocation. These are the types of dislocations you should know. But overall, the most common type of hip dislocation is a pure posterior dislocation of the hip. Now, I will try to show everything that you need to know about these dislocations. We'll try to understand the mechanism of injury. We'll try to recall and remember the attitude of the limb. We'll try to understand the complications. And then I will give you a table to summarize everything. So please sit back, relax, and listen to what I have to say. And then you can copy that table and everything will be summarized in that table. Easy for your revision before the exam. The first is posterior dislocation of hip. What is the mechanism of dislocation? The usual mechanism of dislocation for posterior dislocation of hip is a dashboard injury. A dashboard injury. So dashboard injury means you'll be sitting in your car. I'll show you the image. Look at the image. This is how you sit in the car, right? So you'll be sitting in the car. This is how you sit in the car. Okay. I think this is on my side, so you'll not be able to see it. Now you'll be able to appreciate this, right? So this is how you're sitting in the car, right? Sitting in the car. Now you go hit somebody. What will happen? Your knee will go hit the dashboard of the car. The moment the knee hits the dashboard of the car, what will happen? Hip will dislocate posteriorly. Hip will dislocate posteriorly. And when the hip dislocates posteriorly, what will be the attitude of the limb? There will definitely be flexion at the hip. There will be adduction of the thigh, and there will be internal rotation or external rotation? Internal rotation. So there is flexion, adduction, internal rotation. With limb shortening or lengthening, there will be a limb shortening. There will be a limb shortening. So that will be the attitude of posterior dislocation of hip. So mechanism of injury is a dashboard injury. Attitude will be flexion, adduction, and internal rotation with shortening of the limb. Right, with shortening of the limb. And I'm sure you can identify that on X-ray, right? So this is the most common type of dislocation, posterior dislocation, dashboard injury. Now let me show you a clinical patient. Let me show you a clinical case. This is a patient who came to us with a history of road traffic accident. Look at her left lower limb. Can you look at the attitude? What is the attitude? There is some flexion at the hip. Definitely there is adduction. How can you say there is adduction? The key point to look for adduction is, look at the knee. Where is the knee? Knee is on the other limb. Knee is on the other limb, and there is internal rotation. Can you appreciate the internal rotation? Yes. So there is flexion, adduction, internal rotation, and there is some shortening also, which you might not be able to appreciate on the image, but this is the attitude. Now look at the X-ray. Again, this is the normal side. What are you noticing on the normal side? X-ray, Shenton's line is there, which is intact and continuous, but on the dislocated side, the Shenton's line is broken. The head of the femur is outside the acetabulum. The thigh is adducted, and there is no visibility of the lesser trochanter, suggesting it's internally rotated. And the GT tip is at a higher level, suggesting that there is shortening. So flexion, adduction, internal rotation with limb shortening with the dislocation on X-ray is a pure posterior dislocation. Again, this is what I want you to appreciate and understand. Okay, so you've understood the mechanism of injury. You've understood how the attitude is. You've understood how it is represented on X-ray. That is all you need to know about pure posterior dislocation. Now what about anterior dislocation? Anterior dislocation usually occurs because of a deceleration injury. Deceleration injury means suddenly the speed comes down, means falling from height. When you're falling from height, you have high velocity, and suddenly on falling down, your velocity comes down. A deceleration injury, falling from height. Now what will be the attitude? Exactly the opposite. What is the attitude of posterior dislocation? Flexion, adduction, internal rotation with shortening. Here the attitude will be flexion at the hip, but there is abduction and external rotation with limb lengthening. Again, everything is written. Don't worry. Just listen to me. Like I said, listen to me here. Everything is written. Okay. Flexion, abduction, external rotation with limb lengthening. That is the attitude of anterior dislocation. Look at this X-ray. This is the normal side. Shenton's line is intact. Here the Shenton's line is broken. Head of the femur is outside the acetabulum. Lesser trochanter is fully visible, means externally rotated. Tip of the greater trochanter is distally migrated, so lengthening. Now look at this attitude. Look at this attitude. This is the pathological side. What is the attitude? There is some flexion at the hip. There is abduction. And a little bit of external rotation. Little bit. So this is flexion, abduction, external rotation. This can be an anterior dislocation of hip. Okay. This can be an anterior dislocation of hip. Now what about fracture dislocations? What will be the mechanism of fracture dislocation and what will be its attitude? Listen to me. Everything is written here. Just listen to me. The mechanism of injury for fracture dislocations can be anything. When I say anything, you don't have to remember anything. It can be anything. It can be a complex force, so you don't have to memorize anything. But this is what I want you to remember. When it comes to attitude, the attitudes of fracture dislocations again can be anything. But it will not be the attitudes of pure dislocation. This is what I want you to remember at this level for your exam. So attitude of pure dislocation is flexion, adduction, internal rotation with shortening. Attitude of anterior dislocation is flexion, abduction, external rotation with lengthening. These are pure attitudes. They cannot be disturbed. They should not be changed. They are pure for pure dislocations. For fracture dislocations, it can be anything other than this. So if you change one parameter of this attitude, then it is usually a fracture dislocation on your exam. Right? It's a fracture dislocation on your exam. It can be anterior fracture dislocation, it can be a posterior fracture dislocation, or it can be a central fracture dislocation. So it can be an anterior fracture dislocation, posterior fracture dislocation, or central fracture dislocation with an attitude that is different from the pure attitudes. Now, the question is, sir, if it can be anything, then how will we know what is what? It is very simple. You will look for the head of the femur post-dislocation clinically. Post-dislocation, if the head of the femur is palpable in the gluteal region, it means the head of the femur is in the gluteal region, means it is posterior, means it's a posterior fracture dislocation. If post-dislocation, the head of the femur is palpable in the scar-pass triangle or the femoral triangle or the anterior triangle of the thigh, then it is anterior fracture dislocation. If post-dislocation, the head of the femur is palpable inside the pelvis, then it is a central fracture dislocation. The question is, how will you palpate inside the pelvis? You can palpate anteriorly, you can palpate posteriorly, but pelvis ke andar kaise? You can palpate by doing perrectal examination. When you do a perrectal examination, you will feel the head of the femur, right? So if the attitude is anything other than the pure, with the head of the femur inside the pelvis, central fracture dislocation. With the head of the femur in the gluteal region, posterior fracture dislocation. With the head of the femur in the scarpas of the femoral triangle, it's anterior fracture dislocation. Clear? Hai? Now look at this X-ray. What is the problem here? This is Shenton's line. This is Shenton's line, looks like it's disturbed here. You can clearly see that the head of the femur has fractured the floor and moved inside. Here you can see the acetabulum is nicely congruent. Here you can see that it is fractured and the head of the femur has moved inside. This is a central fracture dislocation. This is a central fracture dislocation. Okay. Now let me summarize everything with the table that I have provided to you. Look at this table. This is magic. You'll be able to answer almost every MCQ when it comes to dislocation. So dislocations can be pure or it can be fracture dislocations. Okay. Pure are only two. Most common is posterior dislocation, other is anterior. Mechanism of injury for posterior dislocation, dashboard injury. For anterior dislocation, deceleration injury, that is fall from height. What is the attitude for posterior dislocation? Flexion, adduction, internal rotation with limb shortening. Attitude for anterior dislocation, pure. Flexion, abduction, external rotation with limb lengthening. That's it. That's all you need to know. What about fracture dislocations? Posterior, anterior and central. It is a complex mechanism. And any attitude will be seen in the patient other than the pure attitudes. Other than the pure attitudes. These attitudes will not be seen. These attitudes will not be seen. So how will you diagnose it clinically? Look for the head of the femur. If you find the head of the femur in the gluteal region, posterior fracture dislocation. In the femoral triangle, it's anterior fracture dislocation. And if you find the head of the femur perrectally, on perrectal examination, then it's a central fracture dislocation. Now with that clarity out of the way, let's move on to the management of hip dislocation. Any dislocation in the body is an emergency. Your aim is to reduce it as soon as possible, particularly with hip dislocation because the complication. You know the proximal femur has precarious blood supply. We'll go into details in just a bit. And if the head is dislocated for more than 6 to 12 hours, the chances of avascular necrosis of the head of the femur will be very, very high. Right? That is the most common complication. That is why you have to reduce it as soon as possible, ideally within 6 to 12 hours. Now, what are the techniques of reduction? There are many techniques of reduction, but you don't need to know all of them. I'll just show you the names. If you can remember them, great. If not, it's okay. But whatever you do, quickly attempt the reduction. So the first attempt of reduction is usually a close reduction. You just try to reduce it with the technique provided. If the limb does not relocate because of the strong spasm or pull of the muscles, you can attempt close reduction again with the help of anesthesia, under anesthesia, because anesthesia will relax the muscles. If it is not reducing under anesthesia as well, then you can go for open reduction. Obviously, when you open, you will need anesthesia. So open reduction should be the last method of trying to reduce the head of the femur in a hip dislocation case. Okay? Right. So these are the steps to be followed. A few named techniques of reduction. One is Ali's maneuver, other is Bigelow's maneuver, other is Stimson's maneuver, and then East Baltimore maneuver. So these are the names. If you can remember them, great. If not, it's okay. Now, another clinical sign that I want you to remember that is seen in hip dislocation, particularly the posterior hip dislocation, is vascular sign of Narath. Now, if you have attended the pediatric modules, or if this is your second go through the videos, you will know that vascular sign of Narath is something that I've already discussed in pediatric orthopedics. Now, what is this vascular sign of Narath? Now, you see, whenever you palpate an artery in the body, you palpate it against a bone, right? You palpate it against a bone or a bony prominence. Similarly, the femoral artery is palpated against the femoral head. Now, in case of a hip dislocation, will you be able to palpate the femoral artery? No, because there is no head behind the artery to palpate it. It might be female. So this inability to palpate for the femoral pulsations compared to the opposite side, it is what is known as a vascular sign of Narath. Now, before you memorize and mug this up, try to understand why you get this. In any condition where the head of the femur is not in its place, you will get a vascular sign of Narath. Very simple. For example, if you've surgically gone in and removed the head, what will happen? You'll get a vascular sign of Narat. If there is a developmental dysplasia of hip, you'll get a vascular sign of Narat. If there is a disease process that has destroyed or eaten away the head, you will get a vascular sign of Narat. Right? So you don't have to memorize. So minimize what you memorize. Try to understand the logic behind it, and once you know the logic, it becomes perennial. It becomes permanent. It'll stick to you like Fevikwik. Okay, so that is vascular sign of Narat. Now moving on to the complications of hip dislocations. Like I've said, the most common complication is avascular necrosis, particularly if you delay the reduction by 6 to 12 hours. That is why try to reduce it as soon as possible. The other few complications are the nerve injuries that occur. In case if you have a posterior dislocation of hip, the nerve that gets injured is the nerve behind the hip. Which nerve is that? Sciatic nerve. Excellent. And if you have an anterior dislocation of hip, which nerve will get injured? Let me give you an option. Let me give you options. Radial nerve, median nerve, ulnar nerve, or femoral nerve? Yes, femoral nerve. Excellent, excellent. Right, so anterior dislocation of hip, you will injure the femoral nerve. Now moving on to the proximal femur fractures. But before we talk about proximal femur fractures, by the way, proximal femur fractures matlab we are going to talk about neck of femur fracture and intertrochanteric fractures. But before we talk about that, please understand the reason we are going to talk about them together. The reason we are going to talk about them together is that they occur very close proximity to each other. For example, what is neck of femur fracture? It is the fracture of the neck of femur. Genius, right? It's a fracture of the neck of the femur. This part. This is the neck of the femur. So a fracture here is the neck of the femur fracture. Now what is intertrochanteric fracture? It is the fracture that runs between the greater and the lesser trochanter, right? So this is the intertrochanteric fracture, a fracture line that passes through this. I'll show you the images here. I'll show you the images. So this is the intertrochanteric fracture. This is the neck of femur fracture. Now they occur so close to each other. Yet their outcomes are so different. They are so close to each other anatomically. They occur in almost the same demography. They present to you also clinically similarly. But their outcomes are drastically different. If their outcomes are different, their management and treatment also becomes different. Right? We need to understand why this. So why this difference when the fractures are so close to each other? The secret lies in the blood supply to the head of the femur. Now quickly review the blood supply of the proximal femur or the head of the femur. You must have read this in anatomy. You see, the head of the femur receives its blood supply from profunda femoris artery. Now this profunda femoris artery gives two important branches, the medial femoral circumflex artery and the lateral femoral circumflex artery. Now both of these make a ring, make this ring, and then from this ring send blood supply to the head of the femur. There is an MCQ here. They've asked this in anatomy. Of the two femoral circumflex arteries, which is the predominant source? It is the medial femoral circumflex artery that is the predominant source. That is the predominant source of blood supply, and it runs behind. And it runs behind the intertrochanteric line. So medial femoral circumflex artery is behind, lateral femoral is anterior. Both of them make a ring, and from that the blood goes to the head of the femur. Okay, now listen to me. Now, neck of femur fracture is the fracture that occurs here at the neck. So obviously this fracture will disrupt the blood supply to the head of the femur. And intertrochanteric fracture occurs here. When you have a fracture here, it will not disrupt the blood supply. So the chances of AVN and non-union are much more with neck of femur fracture, and the chances of malunion is much more with intertrochanteric fracture. Please understand this. Okay. Now another beautiful thing that I want you to appreciate here is that this intertrochanteric line is also the anatomical landmark for the insert of the capsule of the hip joint. So this intertrochanteric line is where the capsule of the hip joint also inserts. So any fracture proximal to the intertrochanteric line is considered a fracture that is inside the capsule of the hip joint. In other words, intracapsular fracture. And any fracture that occurs outside the capsule is considered as and any fracture distal to the insertion of the capsular attachment or distal to the attachment of the capsular attachment, that is the intertrochanteric line, is called an extracapsular fracture. So neck of femur fracture is an intracapsular fracture, and intertrochanteric fracture is an extracapsular fracture. So look at this. This is where the capsule would insert, right? This is where the capsule would insert. So neck of femur is intracapsular fracture. Intratrochanteric is extracapsular fracture of femur. Okay? You've understood how they are different, and you've understood why one goes into AVN and non-union and the other goes into malunion. And there are many more reasons why neck of femur goes into non-union and AVN. I'll discuss that. But let me show you the x-rays so that it becomes second nature for you to pick these up on image. So look at this side. This is obviously an x-ray of pelvis with both the hip joints. Shenton's line is intact. Shenton's line is broken, right? Shenton's line is broken. This is clearly pathological side. There is a neck of femur fracture. This is clearly a neck of femur fracture here. This is a fracture of the neck of the femur. Intracapsular neck of femur fracture. What about this side? Shenton's line is intact. There is disruption here. There is a fracture here. And the fracture line is intertrochanteric. You can clearly see that the lesser trochanter is fractured here. There is a fracture passing through the greater trochanter also. This is extracapsular fracture or intertrochanteric fracture. Now, since they are so close to each other, why not compare them and study? So this is the comparison table. Look at me. I'll explain. Just pay attention and trust me, it becomes easy for you. So neck of femur fracture, also known as intracapsular fracture. Intertrochanteric fracture, also known as extracapsular fracture. Now, what is the usual age group? Both of them occur in elderly population. Neck of femur in 50 to 60, intertrochanteric 7 to 80. Elderly, slightly more elderly here. Right. Sex, both of them occur in female more than males, female more than males, female more than males. Trauma, what kind of trauma will give you these fractures? They're usually fractures that occur in old, elderly, osteoporotic females and patients. Remember? Yes. What is the most common fracture in osteoporosis? Spine, followed by hip, followed by Colles. So this is the hip fracture we are talking about. So what kind of trauma will give you these fragility fractures? Mild to moderate trauma, right? So mild trauma, trivial fall will give you neck of femur. Moderate to severe fall, intertrochanteric fracture. A little bit more force is required. What about pain? Neck of femur fracture, because it's inside the capsule, less painful. So mild pain. Intertrochanteric fracture, moderate to severe pain. So more pain, extra pain. What about the pain? Where will the pain be? Where will the pain be? For neck of femur fracture, the pain will be here. For intertrochanteric fracture, pain will be here. But clinically, how will it be different? For neck of femur fracture, the pain will be in the scar-pass triangle or the femoral triangle here. Okay, this will be the location for the pain. So the pain will be here in neck of femur fracture, and the pain will be in this region for intertrochanteric fracture. Okay, so pain in the scar-pass triangle for neck of femur fracture, pain in the trochanteric region for intertrochanteric fracture. Okay. Now, whenever there is a fracture of the proximal hip, what will happen? There will be some amount of shortening and some amount of external rotation. Now, shortening less than 1 inch is seen in neck of femur, more than 1 inch is seen in extracapsular fracture. So, more shortening. External rotation will also be there. External rotation of less than 45 degrees neck of femur, more than 45 degrees in intertrochanteric fracture, so more external rotation also. And I'll tell you why. You see the capsule has inserted the intertrochanteric line. If there is an intertrochanteric fracture, it means the fracture is distal to the capsule, so there is significant amount of external rotation, more than 45 degrees. More than 45 degrees. In fact, it's so much so that the patient's foot will be so much so externally rotated, the lateral part of the foot will be touching the couch. Look at how much external rotation it is. Okay. Almost 90 degrees of external rotation is there. Lateral part of the foot is touching the couch. This is a classical presentation. You go to your orthopedics ward, look at the patient with a hip fracture, look at the limb, you can make the diagnosis whether it's intertrochanteric or neck of femur. Neck of femur fracture, what happens? Because the capsule is still attached and the fracture is proximal to the insertion of the capsule will resist external rotation. So you will not get significant external rotation. External rotation hoga, but not so significant. So it will be less than 45 degrees. Okay? Please appreciate that, understand that. If it is severely external rotated, lateral part of the foot is touching the couch, then it is intertrochanteric fracture. Now, in terms of complications, I've told you neck of femur, avian more than non-union, and intertrochanteric fracture. Malunion, which malunion? Coxa-Vara. And whenever you have Coxa-Vara, the neck shaft angle decreases, which gives you which kind of gait? Trendelenburg gait. Are you understanding? So these are the key differences between neck of femur and intertrochanteric fracture. And a lot of people summarize this very simple way, in a very simple way. What do they say? They say extracapsular fracture, everything seems to be extra. Everything seems to be extra. The age is extra. The velocity of trauma is extra. The pain is extra. The shortening is extra. The external rotation is extra. And even the healing is extra. So extracapsular fracture, everything is extra. Extra external rotation, extra shortening, extra pain, and everything. Right? And finally, coming back to why does neck of femur fracture go into non-union? I've told you one is the blood supply. Okay? Because of the vascularity. There are two more important causes. One is because the neck of femur fracture is inside the capsule. which is constantly being washed away by synovial fluid has inhibiting action on the fracture. So it inhibits healing. Another important thing is the periosteum lining the neck of the femur lacks cambium layer. Now, if you recall from the basics, I've told you that there is periosteum and endosteum surrounding the long bones, right? Now, under the periosteum, there are osteoprogenitor osteoblast, whose function is to basically synthesize the bone and help the bone grow in thickness. So, this periosteum around the neck of the femur lacks that layer. Means unke paas wo layer nahi hai. It doesn't have that layer. And if that layer is not there, the osteoprogenitor osteoblast will not be there to help in healing. So, these are the reasons why neck of the femur fracture usually go into non-union. Now, once we've understood that these are the clinical differences between neck of femur and intertrochanteric fracture, let's move on to the management. What do we need to do? We need to manage neck of femur fracture and we need to manage intertrochanteric fracture. Okay. Now, we'll talk about them separately. Let's start with neck of femur fracture. The first thing you should do is you should classify the fracture because MCQ aate hain, right? There are 3 classifications you should know for your exam. The most important one is anatomical classification, where you classify the neck of femur fractures based on the fracture line anatomically. Okay, so look at this. This is the head of the femur. This is the neck of the femur, right? So head is also known as capitulum, all right? Capitulum. So if the fracture line is just under the head, so this is subcapital fracture. Another is through the neck. Through is trans, neck is cervical, transcervical. And third is at the base of the neck, base is basal, neck is cervical, basicervical. These are the 3 types of fractures of the neck of femur anatomically. What is the significance? More proximal the fracture, worse the prognosis. So among this, which has the worst prognosis? Subcapital has the worst prognosis. Which has the best prognosis? Basicervical has the best prognosis. Okay, you've understood this. This is the anatomical classification. Second is Powell's classification. Now, what is the principle here? Powell's classification is based on the angle subtended by the fracture line. This is important. What do I mean by this? For example, suppose this is the horizontal reference line and this is the fracture. This is the fracture. Okay, it can be anywhere. It can be here, it can be here, it can be here, doesn't matter. We are not looking at the location of the fracture. We are looking at the angle it makes with the horizontal. Okay, so if you draw a line across the fracture and then you measure the angle, this angle is what is known as Powell's angle. This angle is what is known as Powell's angle. Again, I am reiterating this because a lot of you have this doubt for some reason, I don't know. It doesn't matter where the fracture line is, whether it's subcapital, transcervical or basicervical. We are just looking at the angle subtended by the fracture line with the horizontal. That is known as Powell's angle. Now, more the angle, poorer the prognosis. So we have divided into grade 1, type 1, 2, 3, 30 degrees, 50 degrees, more than 50 degrees. Okay, 30 degrees, 30 to 50, more than 50. So 1, 2, 3. Why is this important? Because suppose this is the horizontal line and this is the angle of the fracture. If the angle is less, what does it mean? If you put weight on it, the fracture can get compressed. If the angle is more, what will happen? If you put weight on it, there can be displacement. There can be displacement. This part can go down and this part will go up. There will be displacement. So more the angle, poorer the prognosis. More the angle, more vertical it will be and more unstable the fracture and more poor the prognosis. Okay? Just please understand that. Nothing to do with where it is, just the angle, Powell's angle. The third classification is the least used classification, is Gardner's classification. Now what is this? This is based on the trabecular alignment. What are trabeculae? Trabeculae are the lines that you would see in the bone, on X-ray. Okay, these are the lines that you would see on the bone on X-ray. So trabeculae will be in the acetabulum, in the head of the femur and in the neck of the femur. Based on that, you have classified this into 1, 2, 3 and 4. Gardner stage 1, 2, 3 and 4. To simplify this, remember, stage 1 and 2 are undisplaced fracture. Stage 1 and 2 are undisplaced fracture. Stage 3 and 4 are displaced fractures. Okay. So 1 and 2 are undisplaced, 3 and 4 are displaced. So what is 1? 1 is an incomplete fracture. 1 is an incomplete fracture. Undisplaced and incomplete. What is 2? Undisplaced but complete. Sometimes 1 is also known as valgus impacted fracture. So 1 is undisplaced incomplete, 2 is undisplaced complete fracture. What about 3? 3 is displaced but partially displaced. 4 is displaced, but completely displaced. That's all you need to know. And one important MCQ you should know is in type 2. Only in type 2 will the trabeculae alignment maintained between the acetabulum, the head, and the neck of the femur. Okay, the trabecular alignment is maintained only in type 2. Right. So these are the classifications. This is what you need to know. Now coming to the treatment, the actual treatment of neck of femur fracture. But before I begin telling you the neck of femur fracture treatment, let me just give you a disclaimer here. Neck of femur fracture is considered as an unresolved fracture. Now what do you mean unresolved? Unresolved means something that is not resolved, something that has no clarity, something that has a lot of confusion. Neck of femur has a lot of confusion. So there are constant updates coming along for the management of neck of femur, but I don't want you to worry too much about it. Just try to understand and memorize whatever I am telling you about the management of neck of femur fracture. And it is the simplest way of understanding this complex topic. Now, what is neck of femur fracture? It is a fracture of the neck of the femur. Whenever a patient comes to you with a neck of femur fracture, the first thing you should look at is the age of the patient. Very, very important. You should look at the age of the patient. Why? Because if you remember from the previous slides, the most common complications of neck of femur fracture are avian and non-union. And both of them are roughly around 40 to 45 to 50%. So let's assume 50%. So 50% of the patients, irrespective of whatever you do with the fracture, will have a complication of non-union and or avian, which means that the patient will be unable to use the hip. Which means if it's an elderly patient who comes to you with neck of femur fracture, he will not be able to use the hip, which means he should be bedridden. And if he's bedridden, can you imagine what will happen to him? Plethora of complications, bed sores, recurrent infections, UTI, nutritional deficiencies, okay, depression. And that is why, a few decades ago when neck of femur fracture was not properly managed, a lot of patients would die within a few months after the neck of femur fracture. It was considered a terminal fracture. Now, thanks to the recent advances and modern orthopedic management protocols, we have actually changed the whole spectrum of neck of femur fracture patients' outcome. Okay, so please understand this. Whenever a patient comes to you, look at the age. If he's elderly, what is the elderly cutoff? 60 to 65. In orthopedics, think 65. If he's a patient more than 65, thank your stars, because the treatment becomes very simple. The treatment is to go and replace the head because it has fractured and the chances of union are less. Do not waste the time of the elderly patient. Go in, remove the head, put in a metallic head. The ideal treatment is hemiarthroplasty. That is half replacement, hemiarthroplasty. But please understand this. If a patient had a pre-existing hip problem, as in osteoarthritis of the hip, then instead of only replacing the head of the femur, might as well replace the acetabulum also, because he already had problems. So go for a total hip replacement. Simple. Neck of femur fracture patient, look at the age. More than 65, go for hemiarthroplasty. If he had a pre-existing hip problem like osteoarthritis, then go for total hip replacement. Done and dusted. Now I'll tell you the implants that you will use in hemiarthroplasty, the process, I'll show you all of that. But this is to give you a general idea. Now if it's a younger patient, less than 65, then you will not go for replacement immediately. You can at the end of the treatment protocol, but immediately no. Why? Because it's a young patient. You would want to salvage the head as much as possible, because a natural hip will always be better than an artificial hip, because the expectations of a young patient are different from the expectations of an elderly patient. We all know this. Right. So what will you do? When a young patient comes to you, try to look at the age of the fracture. What do you mean age of the fracture? If you recall from our basics, I told you callus formation happens earliest by which duration? 3 weeks. 3 weeks. So if it's a fracture before 3 weeks, means callus has not yet formed. Means you can reduce the fracture and fix it. And if it's been 3 weeks already, it means that the callus has already started. It means your attempts to reduce the fracture will not work. And even if it does, the complications might start to set in, like avian and non-union. So you need to see when the fracture occurred. If it's a fresh fracture that is within 3 weeks, then go for fixation. I'll tell you what device you use. You will use cancellous screws, close reduction, internal fixation with cannulated cancellous screws. That you will do. Everything is written. Just listen, understand the theme here. Okay, so you'll fix it. Now, if the fracture is 3 weeks old in a young patient, then what will you do? You need to assess if the head of the femur is viable or not. Avian has set in or not. How will you assess that? What is the investigational choice? investigation of choice is MRI. Do an MRI, look for the viability of the head. If the head is not viable, fix the fracture and give it blood. Some vascularization procedures. If the head is viable, then you can go for the other complication, that is non-union. To prevent that, what will you do? Osteotomy. To prevent that, you will do osteotomies. If the head is viable, to prevent the other complication, that is non-union, by performing osteotomies. Okay? Or if the head is not viable, if the head has already died, then you will go for replacement. There is no other option left. Are you following me? If the head is already died, no. Viability is compromised, try to provide blood immediately so that it can be salvaged. If it is already dead, then you have to go for replacement. You know that. If it is viable, try to protect it as much as possible. If it is going into non-union, perform osteotomies. Viability is questionable, give blood supply. It's going into non-union, perform osteotomies. If it is already dead, go for replacement. Okay, this is a general idea. Let me give you more specific or better version of it. First thing, look at the age of the patient. More than 65, replacement. Two options, hemi or total. Hemi is preferred unless there was arthritis, in which total will be preferred. Hemi, what are the options you have? You can do Austin Moore, Thompson or bipolar. Best is bipolar prosthesis. I will show you this. Young patient, less than 65. Chronology of the fracture or age of the fracture. Fresh fracture, close reduction, internal fixation with cannulated cancellous screws. Not a fresh fracture, do MRI to look for viability. Not viable, fix and provide vascularity. Options are Meyer's, Bakshi's vascular procedures. Names, just the names, I'll show you. If viability is not the concern, try to prevent non-union, or if non-union has started to set in, perform osteotomies. Two options you have, fix and perform osteotomies like McMurray's or Powell's. Powell is better than McMurray. Okay, some idea you got. This is what you will do. Now, young patient, fresh fracture, what will you do? Close reduction, internal fixation with cannulated cancellous screws. This is what I have done here. I have done a close reduction, internal fixation with cannulated cancellous screws. Sometimes you can use 3, sometimes you can use 4 screws. Fix kar do, it will heal. Right. Elderly patient, what will you do? Ideal treatment is hemiarthroplasty. Go and replace the head. Remove the head, throw it out, put a metallic head. What are the prosthesis options you have available? 3 in the market, bipolar, Austin Moore, Thompson. Which is the best? Bipolar. Why? Bipoles. It has 2 sides of movement. One is where the acetabulum articulates with the head and just underneath the head also. So 2 articulations. Whereas these all have only 1 articulation. Okay. So bipolar, head moves separately over a small neck. And the acetabulum moves. Acetabulum, head moves under the acetabulum and the head moves over the neck also. So 2 poles, bipolar. This is the best. Then Austin Moore, then Thompson. Okay, so this is for hemiarthroplasty. If the patient has a pre-existing hip condition like osteoarthritis, go for total hip replacement, where you replace the head of the femur as well as the acetabular cup. Okay, so you've understood that. Now what if the patient comes to you who's young, after 3 weeks, do an MRI, check for viability. If viability is compromised, provide vascularity. How will you do it? Vascularization procedures. You have 2 options, Meyer's or Bakshi's procedures. What do we do in Meyer's and Bakshi's procedures? You basically remove the bone from the insertion of the muscle. You remove the bone from the insertion of the muscle. Basically, you follow the insertion of the muscle and its attachment to the bone is removed with the bone and it is placed on the head. Okay. So bone with its muscle is placed on the neck to provide vascularity. Depending on the muscle that you use, you have the name. Meyer's, you use quadratus femoris muscle. Bakshi's, you use tensor fascia lata. Bakshi is Indian, that's why I thought you should know it. Otherwise, not very important. Not very important. Now, if the viability is good and the neck of femur is not uniting or is going into non-union, you can perform osteotomy. 2 options are available, Powell's and McMurray's. We prefer Powell's over McMurray's. I'll tell you what we do in Powell's osteotomy. Remember Powell's angle, right? More vertical, more dangerous. We are trying to basically change the angle. We are trying to change the angulation of the fracture. Okay, we are trying to change the orientation of the fracture from vertical to horizontal to help it compress. Let me show you. So this is a non-union of neck of femur that has been attempted to heal a fix with the cannulated cancellous screws. Vertical fracture line, not healing. So what have we done? We have performed an osteotomy. We have cut the bone in a way where the neck of femur angle is reduced now. So look at this angle Now look at this angle. It has been reduced now. So this is Powell's osteotomy. We change the orientation. What do we do in McMurray's osteotomy? McMurray's osteotomy is the medialization osteotomy, or we call it the armchair effect. What we do is basically we cut the shaft and medialize it. We cut the shaft and medialize it such that the weight of the body is transmitted from the head directly to the shaft, bypassing the fracture line. Are you following? You cut the shaft and medialize it. When you cut the shaft and medialize it, the weight of the limb will be passed directly from the head to the shaft without passing through the neck. So normally, if you had a neck of femur non-union, right? If you had a neck of femur non-union, the weight would pass like this and then go to the shaft, right? And this non-union would not heal. So what you do is you cut the bone, you medialize the shaft, and so the weight will directly be transmitted from head to the shaft as shown in the image here. Samajh aa raha hai? Are you able to appreciate this? Right? This is known as McMurray's osteotomy. Not done quite a lot. Now let's see whether you've understood this or not. A 45-year-old male with a history of fall. X-ray shows a fractured neck of the femur. History is more than 3 weeks old. What is the best management plan? Is it hemiarthroplasty? 45 hai na? 9. Is it total hip replacement? 45 hai na? 9. Fixation with cancellous screws? It's already 3 weeks. So will that suffice? No. Then you have to go for a viability scan, that is MRI scan, and go for either vascularization procedures or osteotomies. So the best option among the options provided here is McMurray's osteotomy. Okay? For the sake of MCQ, reality might be different. Now the last thing that I want to talk about in neck of femur fracture is this. Suppose if an elderly patient comes to you with a history of fall and there is pain at the hip, what do you think it is? What do you think it is? Yes, it is neck of femur fracture. It is neck of femur fracture. Elderly patient, history of fall, pain at the hip, neck of femur fracture. That's what you should assume as clinicians. Now, what if the patient comes to you walking into the OPD? Still, you should consider it a neck of femur fracture because valgus impactor type, patients can usually walk on it. Okay. No, sir, what if the X-ray is normal? What if X-ray is negative? There is no fracture line on the X-ray? Still, you will consider it to be neck of femur fracture. The only way to confirm your diagnosis is getting an MRI. If on MRI there is no fracture, then you can safely send the patient home. That is how common it will be in elderly patients. Please remember, elderly patient comes to you with a history of fall and there is hip pain. Assume it is neck of femur fracture unless proven otherwise. Okay? For an occult fracture, for an hidden fracture, what is the investigation of choice? Is MRI. Get an MRI to make your diagnosis. That completes our neck of femur fracture. What is left? Our intertrochanteric fracture. Intertrochanteric fracture management is very simple. The outcome is malunion and that causes Coxa-Vara, which will cause Trendelenburg gait. So your aim here is very simple. To prevent it from going into malunion, make sure that you've reduced it properly. The neck shaft angle is maintained. So look at this. This is your intertrochanteric fracture. This is your intertrochanteric fracture. How will you fix it? You will use proximal femoral nail. I will show you, everything is written. You will use a proximal femoral nail. Will you pass a nail and you pass a screw. You pass a nail and you pass the screw. What is happening? The neck shaft angle is being maintained. What is the device? Proximal femoral nail. That is the device that you will use in intertrochanteric fracture. There was an older device which we use sometimes, that is known as a dynamic hip screw. The purpose is the same, to maintain the neck shaft angle. The purpose is the same, to maintain the neck shaft angle. The only component you need to remember is that it has something known as a sliding compression mechanism which we use with the screw, that is the dynamic hip screw. Okay? It causes compression. We call it a sliding compression mechanism which is based on the dynamic hip screw principles. You don't need to. Right? So the malunion is the complication of intertrochanteric fracture, and we all know what is a malunion, Coxa-Vara, and whenever there is Coxa-Vara, what will happen? You will get Trendelenburg limb. Why? Because the greater trochanter is proximally migrated, the gluteus medius and minimus are shortened, and a shortened muscle is a weak muscle. Shortened muscle is a weak muscle, a stretched muscle is a strong muscle. Finally, sometimes what happens is you cannot operate on these patients of intertrochanteric who are extremes of age, or who have surgical contraindications, or who have certain comorbidities which you cannot operate on them. Then you can conservatively manage them on tractions and certain boots. The traction that we use for intertrochanteric fracture is Russell traction. This has been asked as an MCQ. And if the patient cannot be kept on a traction also, the other option is using a derotation boot. Derotation boot. It's a boot which you apply on the patient's limb with a rod. What will that rod do? It will prevent external rotation. So if it prevents external rotation, it will prevent some amount of rotational malunion, which we use in management of intertrochanteric fracture. Not ideal, but that is something that you can use. So essentially that completes our management of hip fractures. A very, very important topic. So 2 topics you should frequently revise from this video is hip dislocations and neck of femur fracture.